without much ado, no disclosures, let's move along. Syndromes with pancreatic cancer. Does everybody already know this? Anybody not know this? Okay, Lynch syndrome, FAP, Poots-Jaggers, lifetime risk, 36%, breast cancer and pancreatic cancer. PanIN, I always got to bring that up, although it's extraordinarily rare. Familial atypical mole and melanoma syndrome, lifetime risk, 19%. They also get melanoma, no surprise with the title there. Familial breast cancer, you got your BRCA1, your BRCA2, your PALB2. They offer about a 5% risk. We don't usually screen those patients unless they have a family member, first-degree family member with pancreatic cancer or symptoms. Hereditary pancreatitis, they have a markedly increased risk of getting pancreatic cancer. We also don't screen them because with the tools we have today, the changes we see that are pancreatic precancer look exactly like chronic pancreatitis. I can't tell the difference. So we don't include them in our screening program, and ditto for cystic fibrosis. So I just very quickly outlined there the syndromes that are associated with pancreatic cancer, but the truth of the matter is that only represents probably 10 to 15% of familial pancreatic cancer. The majority of the patients that have this disease, we don't know. We don't know what causes it, and Gloria Peterson and her teams are working on it. Hopkins is working on it. Many people are working on trying to discover what these genes are. So how do we address this familial risk? So one thing that I can tell you that's actually good news is you treat all these patients the same. So even though it's a heterogeneous cause for the disease, their management is all about the same. Now, in terms of trying to figure out what is a personal risk for a patient in terms of their risk of getting pancreatic cancer, it depends on the gene involved, okay? And not all gene carriers get cancer. So for example, if you're BRCA2 carrier, your lifetime risk remains quite low. It's 95% of the time your risk is not going to turn you to get pancreatic cancer. So it's dependent upon the gene, and it's important to remember just because you have a gene mutation doesn't mean you're going to get the cancer. And that's because the penetrance of the gene can vary according to what the gene is. So if you have a pallidin gene mutation, you have a 100% risk of getting pancreatic cancer, whereas, as I just discussed, BRCA1 and 2, it's a lifetime risk of 5%. So how can we do surveillance for these high-risk patients? And I know a lot of people like to throw tomatoes at this. They think that you shouldn't do surveillance, and if you find something early, what are you going to do with it? And if you operate, you shouldn't operate, and maybe we should just let them all go home. So you have to understand that as a clinical physician, I see patients in my clinic. They tell me, my mother, my brother, and my son died of pancreatic cancer. You know, what can you do for me? And, you know, I could send them home, but I have the urge to try and help them. You also have to understand we're limited in what our tools are. And Mimi Canto has been running a huge program, and she knows this too. I wish we had different tools, but you have to work with what you've got. And it's like that Apollo flight where, you know, they got breakdown out in outer space, and you have to make it work with some duct tape and, you know, toilet paper rolls. And so that's what we're trying to do here. We're trying to make it work. We got some duct tape, we got paper rolls, but at the end of the day, you know, we'll make some better tools to use. But right now, this is what I have. This is what Mimi has. We got to make it work. So let's talk about what do we want to target? So what is the Holy Grail? What are we looking for? So first of all, let's talk about how pancreatic cancer forms and where the early lesions are. So I drew this little pancreas here, and here's the interesting news is pancreatic cancer, I'm going to talk about adeno-CA. It's usually forms by the precancerous lesions or in the small side branches. And so if you're looking in the main duct, you are not going to find it. And modalities that look at the main duct are not going to find it. So when we think about how are we going to get at the heart of this, you have to think about modalities that can pick up tiny lesions in the side branches of the pancreatic duct. That is a very tall order. Okay. So at the end of the day, the sun rises and sets on your pathologist. And that's right, Annie, that's you. So let me give you an example. This is PanIN II, and this is a normal pancreatic duct here, and you can see that these cells are all lined up with their bottom on the basement membrane. They're behaving, very good children in school, everybody's sitting down. Now these are my children right here. You see they're jumping around, they're flying out of their seats, their nuclei are too big, they're disordered. These are troublemakers right here. That's PanIN II verging on PanIN III. This is PanIN III. Now, here's a nice feature about this. This gives you a prime example of what we see in these families. Look, almost normal, sitting right next to, oh my gosh, I'm going to break through the basement membrane and be a cancer any minute now. And we see that all the time. Happy normal cells sitting right next to troublemakers. And the way that you know this is PanIN III is these cells here are completely disoriented. They don't know where up is. And they're floating around in the lumen. They're pinching off little finger-like projections. The only reason this is not cancer, the only reason is it didn't go this way. Hasn't moved into the parenchyma yet. But the day it moves in there, you're in trouble. And then you've got the incurable disease. So this is PanIN III, and I think that that is our target lesion. Why? Why is PanIN III your target lesion? Because if you get pancreatic cancer, really, despite that good vaccine stuff right now, our survival rate does not remain robust. And so my feeling is if, you know, these very small lesions, 1-2 centimeter, they can already have metastases. I'll get more to that later. So I don't think you want to target a mass. I think you need to look for these PanIN III lesions and try and target those. So I'm going to review. We have over 200 familial pancreatic cancer patients in surveillance, and you know, Hopkins has even more than that. Ours is one of the longest running programs in the world. These represent over 100 different families. It's a very heterogeneous group of people. Most of them, we don't know what causes the disease. Average years of surveillance, 5. So our task at hand, as I've pointed out to you, is to identify patients after they've started down the neoplastic pathway, but before it becomes invasive. So for surveillance, what we include in our surveillance program, if you have a mutation that gives you a risk of pancreatic cancer, a risk that's sufficiently high, in this case the cutoff is 15%, so I'm going to tell you why later, or you have 2 family members, one of whom is a first-degree relative, you can buy your way into our surveillance program. And we start out with EUS as our baseline exam. This is a very, very subjective exam. It is like telling when does blue turn to green. Everybody's got a different idea. So it really needs to be done at centers where they have a lot of experience and should not be tried at home. And this is one of the great limiting steps in managing these patients is there's not a lot of centers with, you know, vast experience for this. So that is a real conundrum. Okay, but we'll get more to that later, how to get around that conundrum. Okay, so we start out with the endoscopic ultrasound. If it's normal, I ask them, come on back in a year. If it's abnormal, we tend to do ERCP where you're getting a view of the pancreatic duct and its side branches. Why do we do that? We do that because the money is in the side branches. We have often done MRCP. I'm not against MRCP. I like MRCP. But MRCP doesn't give you a good view of the side branches, but it can give you a lot of information about cystic lesions. So there's a risk and a benefit of ERCP versus MRCP, and that's a conversation that needs to be had with the patient. There's a risk of pancreatitis with ERCP, about a 5% risk, or slightly lower, because these people all have abnormal pancreases that are already scarred. And there's really virtually no risk from the MRCP, but you get more data on the ERCP. So always good to go back to the patient and get their feedback. And if they feel, yeah, MRCP, let's go. That's the one. Okay. So if the examination of these side branches is negative, back into the hopper for the EUS people go. If I see that there's abnormalities on these side branches and I'm getting worried and the changes are progressing over time and these are strongly at-risk patients, I have a conversation about getting a piece of tissue, because at the end of the day, we do not know whether precancer is there or not unless you look under the microscope and see it. So the diagnosis must be made off of a piece of tissue. When we go get that piece of tissue, we target either an area that has something good in it, something juicy, or if it's just diffuse abnormalities with little ectatic side branches, we'll go get a piece of the tail. And we try to do it all laparoscopically if we can. If they have PanIN III, we have a conversation with the patient that goes like this. We do not know the natural history of pancreatic cancer or its precursor lesions. We do know that PanIN III is not found at autopsy studies. Not found. It is not some indolent little lesion that hangs around like DCIS of the breast or, precancer in the prostate where everybody has it. A lot of those lesions are indolent, they never change. In pancreatic cancer, PanIN III is not seen at autopsy, and when it is seen, it's seen with pancreatic cancer. So this is not an indolent lesion. But how long will it take for you to move forward? I have no idea. And there is a study out of Hopkins looking at people that have PanIN III, small case report study, and it ranged from 18 months to 17 years. I mean, huge. So we don't know what the right answer is, and it probably varies from patient to patient. So we try to give them the training. If we take your pancreas out, you're going to be a diabetic, you need to learn how to work with insulin. I'm going to send you to diabetes clinic for a month so you can learn how to do that. We don't leave part of the pancreas behind because PanIN III is found throughout the pancreas. What's in the head is what's in the tail. So you don't want to leave part of that gland behind because you'll develop a cancer later. Okay, so these standard adjunct tests, not helpful, not helpful, not helpful. CT scan, never helpful. All right, so if the EUS, ERCP, MRCP are abnormal and you get worried and things are getting worse, you consider this lap taleiectomy. Get your diagnosis. If it looks like this, do you guys know what that is? Anybody here? No? PanIN III. All right, as I was saying, decision for pancreatectomy is based on histology. I don't do a procedure where we get a frozen biopsy and then take the rest of the pancreas out. It puts too much pressure on the pathologist. A frozen biopsy is not a great way to look at the tissue. When we take our sample out to get our tissue diagnosis, I put the whole thing under glass. This is a multifocal disease, but it can be quite focal. And so you don't want to miss it, so you need to look at the whole specimen under glass. How do you manage it? So for PanIN III patients, we consider, and the word here is consider, total pancreatectomy for the reasons I outlined. It involves a long and lengthy discussion with the patient, and they must be trained in diabetic care before they make their decision. PanIN II, I tend to follow with surveillance. I've never taken out a tissue sample from somebody of our families that hasn't had a minimum of PanIN II, and most of them have PanIN III. If they have insulin-dependent diabetes and PanIN II, we can have a conversation about removing the rest of the pancreas because what are we keeping it for? Okay. And as I mentioned, the PanIN II with the diabetes, we tailor it to the patient, but often have a conversation about removal of the pancreas. Now, this is what it looks like. So this is what you're going to see. And this is very telling. Look, if you just look at those, normal, hello, but then you get over here and you're like, ruh-roh. And here's the thing, these will stay happy for maybe a long time, but this guy crosses over and gets in the stroma, and now you've got metastatic disease. And here's another problem. Pretend that this little dot is my FNA needle, and I put it in, and I get nothing. No, wait, I'll put it in over here. Nothing. Oh, wait, over here. No. So this is why FNA is not helpful. I mean, if you hit the big banana over here, that's great. But look how many times I had to put it in to get those cells. The other thing that's really key is when I put an FNA in here, we lose the architecture. And I need to see those finger-like projections. I need to see that they're not oriented to the basement membrane. Management. Decision for total pancreatectomy is based on histology. Patients need diabetes management training before they can make that decision. Ultimately, the choice of continued surveillance versus surgery belongs to the patient. I assist them to follow through with whatever their decision is. Okay, so following 100 high-risk patients, this is what we saw. About half of them have a normal EUS, half abnormal. These patients right here 10 of them progressed over time, and they go in that category. About half of these people ended up with an abnormal ERCP. We had one guy who ended up with a cancer. He had an abnormal EUS, and he came back at 19 months, and we found a 2-centimeter cancer, 2 centimeters, metastasized to the liver. I sent him to Johns Hopkins. All right, some of these people that progress end up getting an abnormal ERCP. If you want to talk about natural history, I have people that had a completely normal pancreas on EUS, normal, year after normal, year after normal, bam, abnormal. Not only bam, abnormal, but then abnormal ERCP, take our sample PanIN III. They got it in a period of 18 months. So the natural history, I think, can vary from individual to individual. Maybe some people, it could go a long time, but I think some people, you can go from normal to PanIN III in a period of 18 months to 2 years. And so you don't really know, who's on that accelerated time point. And that's why I bring people back in a year. So in this case, we had one patient have no surgery. We followed them. 21 patients had surgery. We had 4 partial pancreatectomies, 3 with low grade or PanIN II, 1 with cancer. If you have cancer, the fight is on for the cancer. So I don't see any point in taking out the whole pancreas. We should be so lucky that the person could have a relapse 5 years from now. I think that really what we want to do is maximize their ability to fight their cancer off during the next 18 months to 2 years. So if I see a cancer, I just take the cancer out if it's resectable. We have 17 total pancreatectomies, 5 people with PanIN II who all were insulin-dependent diabetics, and 12 with PanIN III. This is what you see on endoscopic ultrasound. It looks like a snowstorm. It is a snowstorm. This is what you see on ERCP. These little side branches can become ectatic, and they get little blebs on them. And then when you get your tissue diagnosis, it looks like that. Follow up on our 21 surgical patients. Nobody got pancreatic cancer that had PanIN III, and I have people that have been in the program now for almost 20 years, and now I take care of their children, so we're on our 5th generation. Of these people with partial pancreatectomy, none of those have gone on to get anything bad. The one guy that we diagnosed with early cancer, we sent him for partial pancreatectomy. He's alive and well at 7 years. And we still surveillance his tail. Complications. Well, there are complications, and this is why we don't go at it willy-nilly. This is not for the faint of heart. I don't want to send these people to surgery, but I also don't want them to get cancer, and that's why it has to be a huge conversation between the caretaker, the primary physician, and the patient themselves. So we have had one pancreatic duct leak. We've had a couple of episodes of hypoglycemia. I had one guy couldn't tell when he was hypoglycemic. We did a pancreas transplant. He's insulin-free and disease-free, and he's happy as a clam. We had one death due to hypoglycemia, and this almost shut our program down because I was so despondent I couldn't stand it, and I thought, oh my God, I got to stop, period. I have to stop breathing. It was deeply upsetting, and what I learned about this guy did a lot of drugs, and he smoked a lot of dope, and he basically didn't want to come back. He felt, fine after his surgery, but he didn't want to come back for follow-up, and he didn't take care of himself, and he didn't really check his blood sugar. So what I learned from this is a couple of things. Number one is we have to psychologically pre-screen these people just as if you were going to do a transplant on them. The second thing I learned is about hypoglycemia. So just a reminder, if you don't have a pancreas, you don't make glucagon, and glucagon is what gets your blood sugar up when it's down low. So compliance is obviously an issue, and using physiologic doses of insulin, like on an insulin pump, can be incredibly helpful. But hypoglycemia really haunted me, and so I got into this thing about repeated glucose monitoring, and in the end, what I finally did is I went out and bought all of my patients continuous glucose monitors, because I didn't want it to be an issue that their insurance company wouldn't pay it, so I just went out and bought them myself. And then I give them as a gift. And then, well, all they have to do is have their insurance company cover the cost of the sensor. The glucose monitor, you can set it so it goes off with an alarm when your blood sugar drops low. Even if you're sleeping, it will wake you up. A very simple solution. Islet cell transplantation, why don't we do it? We don't do it because I'm worried that there's some stem cells in there, and you may be just inoculating the patient back with the trouble-making cells. Does early detection improve curability? So we've had nobody develop pancreatic cancer who's undergone intervention. We've had, as I mentioned, 2 cancers, one metastatic, who I think probably died, and then one resectable. He's alive at 8 years. And then in the non-surgical cases, we haven't had any pancreas cancers, but we've had other cancers develop, including lung, kidney, and breast. What are our caveats? The U.S. is very operator dependent. Honestly, it's a terrible, to rely on this is terrible. Why do I do it? Because I don't have another choice. Multi-specialty team, we have a diabetologist, a special surgeon. We've got our pathologist on board. We've got Mike Saunders, our fabulous EUS guy, who tells me when blue turns to green. I only care what he thinks. Highly selected patients. Now let's talk about cost effectiveness, because at the end of the day, if this isn't clinically covered by insurance, then you can't get any of these tests done. So we had to prove to insurance companies it is clinically cost effective to do this, and what we found is the number is right, so it's about $17,000 per life year saved, which is on par with what it costs to do colon cancer screening, and it's way cheaper than a pap smear. But screening after age 70 to 75, I hate to say this because I actually know there's somebody in this room that is in that age range. It's not cost effective, and that's because they die of competing diseases. The other thing that's not cost effective, if your lifetime risk of getting pancreatic cancer drops below 15%, it's not cost effective. That's very helpful for me because that's what informed me that I don't need to be surveillance or screening on BRCA2 patients unless their risk is elevated by having first-degree relatives or they smoke or adult onset diabetes. I put that back in the equation and then I know their risk has gone up even further. So, but it helps me decide who should have surveillance and who should not. What are the risk factors for cancer in these families? Smoking, diabetes, no surprise. Personal history of cancer actually turns out to be protective. Number of affected family members. If you smoke, not only are you more likely to get cancer, you get it a decade earlier. Here's the odds ratio. Look, if you have abnormal glucose, you're 5-fold more likely to get PanIN lesions, PanIN II and PanIN III in your pancreas. Smoking, we already hit. Interesting, if you had personal history of cancer and you got chemotherapy, your personal risk is less. So I'm kind of wondering if the chemotherapy you got helped knock back the neoplastic progression in the pancreas a little bit. I don't know. I'm just, we got small numbers here. I don't know the answer to that, but it's something to think about. Summary, 10% of pancreatic cancer can be due to genetics. Most familial pancreatic cancer is probably from unknown genes. Penetrance plays a key role. Gene-environmental interactions are important. Screening is cost effective as long as your prevalence of PanIN II and III is greater than 16%. EUS is what we're stuck with right now. It has to be done at centers of expertise. Glucose intolerance, elevated hemoglobin A1C can serve as an inexpensive biomarker. So if you don't live near a place that has this expertise in EUS, this could be a replacement test that you could do that'd be super inexpensive. So they need to be followed at specialized centers. Only highly selected patients should be given an option of pancreatectomy. Hypoglycemia is a serious problem. Endoscopic surveillance appears to be promising, but we need better. So now I'm going to cut to the chase. This is the most important part of my talk. So let's talk about imaging. So look, when you have to have I'm a GI doctor, so everything has to be compared to food. So here we got your walnut. So if you're getting a CT scan, your lesion needs to be about the size of a walnut, between a walnut and a pea. Okay, not helpful. Endoscopic ultrasound, we can pick up the peas pretty easily and sometimes find even things smaller than a pea. But this is where you're curable. When you get down the size of a piece of rice, so you're talking a couple of millimeters in size, that's the money shot. So how can we get at that? Well, I'm also very cost effectiveness oriented, as you could probably already tell. So, you know, you could build me a really expensive, fantastic test, and if I can't order it from my patient, then I can't order it from my patient. So let's talk about tests that are cheap. Well, my favorite is ultrasound. It's available in any center. It's very common. No radiation exposure. Gotta love that. Serially repeated for follow-up. Cents on the dollar. Practically free. People come in all the time with right upper quadrant pain. We don't think twice about getting an ultrasound to evaluate for gallstones. We don't think twice. Well, it doesn't work very well. So why don't we enhance that with some molecular medicine? We can do that by enhancing the cancer image by lighting up the blood vessels. So how do we do that? We push that button. So when you get pancreatic cancer, and even when you have these early neoplastic lesions, you have neoangiogenesis, so you get these new blood vessels. And they're really important because those are not present in the normal pancreas, and they're not present in chronic inflammation. It's a cancer thing. So what you can do is you can create these microbubbles. I want you to think of them as champagne bubbles. And basically, you hook on something that will bind onto the proteins in the lining of the neoangiogenesis area, the blood vessels. You find what these proteins are, and you put a little ligand on this microbubble, the champagne bubble, and it basically, and then they home in and bind. And you know, the ultrasound likes nothing better than champagne bubbles. It's a dream come true. It really makes it easy. It shouts out at you. So we began to look at molecular ultrasound for pancreatic cancer. And as you probably heard maybe earlier today, or maybe you didn't, Sam Gambier has been interested in this for a while. And there's some initial work being done with VEGF as the target for the neoangiogenesis. And he's doing work on prostate cancer. Okay. So he works with someone at Stanford, Jürgen Willmann. And Jürgen and I sat down, and we were kind of okay about VEGF, but there's some problems with it. And Jürgen like threw the gauntlet down. He's like, Terry, I need some other targets. Let's get going. So I worked on the other targets. And one of the problems with VEGFR is it's present in pancreatitis, like in a lot of pancreatitis. And so if I have a biomarker, an imaging biomarker that lights up pancreatitis, 10% of the people in this room have pancreatitis. So that's not going to be helpful. So what we did was we did proteomics. That's what my lab does when we're not having fun in the clinic. And we came up with some proteins that are present in just the cancer-related blood vessels of the pancreas. And Thi1 was our first candidate. And this is a prime example of a pancreatic cancer. CD31 lights up all blood vessels. There it is, nice. Here's your VEGF. You got nothing. It's not lighting it up because, oh my gosh, I didn't realize this, but a lot of pancreatic cancer does not express VEGF. I mean, I didn't know that, but holy cow. I guess that's why it doesn't work all the time. Okay, but Thi1 is good, and it lights up often in places the VEGF does not light. So it also is not present. So here's normal pancreas with CD31 in brown. So that's your basic, where's your blood vessel? Nothing. Normal pancreas, nothing. Chronic pancreatitis, nothing. Pancreatic cancer, lots of it. So we made the microbubbles and we injected them into KPC mice, and look, that's cool. Lights up like totally. You can find this. This is 5 millimeter. That's the 5 millimeter marker. Hello, kitty. Now you're talking. And this is microbubbles without Thi1. This is a chronic pancreatitis mouse, and this is a normal mouse. I can find a lesion smaller than 5 millimeters. So here's an intravital imaging. Let's move it along because everybody wants a cocktail. Okay, so we're going to follow the microbubbles as they move into the pancreas, and they begin to bind on the lining of the tumor itself. And you can see they're like light up in green here. And if you just give it a second, it's going to be even more dynamic. And it doesn't bind to anything that's not cancer. It only binds to cancer. But at the heart of this all, we just got done saying cancer's not our target. We want to target PanIN III, right? So, there's PanIN III. So we had to look and see, can we pick up PanIN III if we do this? And look, here, this is cool. So this is PanIN III. I know you guys recognize this. CD31, our blood vessel marker. Holy cow. there is more Thy1 in PanIN III than there is in stage 4 pancreatic cancer. It is all over the place, very easy to see. It lights it up like a Christmas tree. And of course, nobody wants to diagnose PanIN II, and so it doesn't pick up PanIN II. It picks up PanIN III, pancreatic cancer. So when we do this over and over and over, which we have and we have and we have, we can detect cancers that are as small as 1 millimeter. So that's pretty cool, because gosh, a vaccine would work for that for sure. Okay. So I just want to highlight with the molecular imaging that my key collaborators are Jürgen Willmann at Stanford, Ruchen Shenpan, Dave Dawson at UCLA, thank you Dave, and Steve Mochtler at Stanford, and this work is really just a joint effort on everybody's part. We are now in the process with Kim Kelly of turning this Thy1 ligand into a human grade, item so we can move it on into the clinical trial, but of course, there's no funding to do that. Oh, I'm all done.